This is Dr. Howard Strassler with a lecture for Restorative 528A, Op11 Module A, and today I'll be talking to you about an update on vital bleaching, a background on vital bleaching, the chemistry of the vital bleaching materials we're using, and the techniques for at-home whitening. And we'll be looking at bleaching, vital bleaching, and whitening being the same thing. And here you're looking at a patient who wanted whitening and who whitened her maxillary anterior teeth using at-home whitening using a tray. Patients have many choices for whitening, from whitening toothpastes, whitening gum, tray bleaching, either provided by the dentist or over the counter, paint-on whitening materials, white strips, 1-hour bleaching, whitening mouth rinses, and the evidence show that some of these products do work in whitening the teeth, removing discoloration, staining from the enamel surfaces. I mean, for our patients, for them, it would be nice if tooth whitening was as simple as a paint job. Unfortunately, these paint-on products don't work very well, and so we're going to look at the techniques that we can use professionally and the products that patients can use over the counter and what their effectiveness is. First, you may have noticed during the holiday seasons that you could walk through a mall and you'd see mall bleaching, booths set up for patients to have whitening, where the patient inserts a tray in their mouth with a bleaching gel, and that the employee of these whitening kiosks puts a light up against the teeth similar to what dentists use. In fact, many of these kiosks, whitening in hair salons, cosmetic salons, at the state licensure boards of dentistry are investigating whether or not these procedures can be done by untrained professionals. For our patients want whiter teeth. Gosh, you can't find a toothpaste that doesn't say whitening on it. And if it were up to the patients, all of our shade guides, and you can see in front of you that all of the shade tabs look like white porcelain that you see in the public restrooms. And our patients want whiter teeth. In fact, if we were to pick a shade tab, we could go to the local Lowe's or Home Depot, go to the white Formica tabs and chips, and that would be what patients would want. Let's talk about patient choices for bleaching. And when I use bleaching, I'm using it synonymously with tooth whitening. First off, the earliest bleaching was done in office, chairside, and later we were using mouth guards similar to the athletic mouth protectors that are used by athletes, using mouth guards trays. There are products that are combinations where we're doing in office in one visit, having the patient wear a tray for a week, and then in another week having them use the tray again, and then in office again. Or over-the-counter products that we can buy in our drugstores, in our grocery stores, in the Walmarts, the Targets of the world, where patients will make a choice. And when we talk about whitening and patient choices, everything really needs to start with a diagnosis. Does the patient have teeth that can be whitened with these whitening materials? And we'll talk a bit about that. First of all, let's take a look at bleaching for the 21st century. What our patients are doing, what our patients deserve and want, as well as what dentists are doing and observing in their dental offices. Because who doesn't want whiter teeth? In fact, in many offices, there's an assistant who's been trained to specifically provide whitening services and a whitening consultation. So let's take a look. A survey of dentists from Dental Products report how many in-office chair-side bleaches are you doing a month? And 60% of the dentists who responded were doing 1 in 5, with decreasing numbers, where 28% of the dentists were doing no in-office chair-side bleaching at all. When dentists were asked how many take-home whitening kits they're dispensing a month, once again, the largest percentage was 1 to 5 kits a month, where only 4% of the dentists were providing take-home whitening kits. But certainly, dentists are providing this service to their patients. When we take a look at in-office whitening for patients experiencing significant sensitivity, 47% of the time, dentists are reporting that 1 to 10% of their patients are having some sensitivity that's significant, would have them stop bleaching in the office, or they'd be uncomfortable. And in fact, the numbers from 1 to 25% are upwards of greater than 70% of the patients. When we look at take-home whitening products, tray bleaching, we can see once again the highest numbers are in the 1 to 10% range, but still 11 to 25% patients are experiencing significant sensitivity. And when we say significant sensitivity, we're referring to patients stopping bleaching because it's so uncomfortable. And this sensitivity is different than root sensitivity, has a very different feeling for the patient. In fact, when patients are asked if they've tried over-the-counter whitening, meaning they've self-diagnosed that they want to whiten their teeth, that the discoloration of their teeth or restorations, they'd like to whiten them, you can see that in the 1 to 50% range, that the majority of patients in a practice have done over-the-counter tooth whitening. And these numbers have been very stable. The economy affects it. Articles in the media affect it in terms of whitening. So over the past year, where patients are asking about over-the-counter whitening, the numbers increased requests for tooth whitening. Does it work? 42%, staying the same 52%, decreased 6%. But certainly, if you take a look, patients are asking dentists, do over-the-counter whitening products work? Meaning that, can I find a more cost-effective alternative to what the dentist is charging for professionally dispensed whitening? So let's take a look at an update of vital bleaching. And professionally dispensed, meaning we as dentists are dispensing these bleaching products. Well, we have choices. In-office bleaching products generally are heat or light enhanced 25 to 35% hydrogen peroxide. And we're doing in-office procedures where we paint the hydrogen peroxide on the teeth. And you'll see examples of the technique in Module 11B. Tray mouthguard bleaching, probably the most popular choice among dental practices, where the patient is wearing a tray, a mouthguard 1 to 2 hours a day, in some cases leaving it in overnight. We have different concentrations, different types of bleaching gels, whether they be chemically hydrogen peroxide or whether they be chemically carbamide peroxides. And I'll talk to you about what the differences are and when we use these different types of peroxide products. There are also professionally dispensed white strips that are very similar to the strips that are used and dispensed over the counter. There are also professionally dispensed preloaded trays of whitening material. Patients also can make the choice of using a combined in-office and mouthguard bleaching, where a light enhanced high concentration bleach is used in the office for an hour. The patient takes a tray home for a week with a weaker peroxide product, and then they come back to the office a week later and then boost up their bleaching with a high concentration hydrogen peroxide product. When we take a look at vital bleaching, tooth whitening for over-the-counter products, our patients can go into the store and they can buy white strips. They can also buy paint-on products. They can also buy preloaded trays. And next time you go to the grocery store, go to the oral care products division area of the store and take a look at the whitening products that the patients can use. and even read the boxes and see what the active ingredients are. In many cases, it'll be either a hydrogen peroxide or a carbamide peroxide. Patients also have other over-the-counter alternatives, non-custom trays where they're using a carbamide peroxide or hydrogen peroxide gel in a tray where one size fits none. They can buy pre-loaded trays. The Aquafresh trays are the most popular. They can buy bleaching toothpaste. They can buy whitening toothpaste. They can use whitening gums. They can use whitening mouth rinses. And there's some clinical data that these have some effectiveness, but certainly the products that work the best, that give us and the patients the best result, are higher concentration hydrogen peroxides and higher concentration carbamide peroxides. And there are over-the-counter products that are equivalent to what we do in the dental office that are equivalent. The Aquafresh trays are equivalent. The white strips are equivalent, but they're limited to canine to canine in the maxillary and mandibular arches, and only for patients that have perfectly aligned teeth, because the white strips need to be touching the teeth in order for them to be effective. So let's look at mouthguard vital bleaching. And here on the upper right-hand side, you can see a tray, a thin, flexible polyvinyl tray that's been adapted to a cast and vacuumed on, similar to making the templates for making provisional restorations. And dentists are using and professionally dispensing gels that are either carbamide peroxide in percentage ranges of 10 to 30%, or hydrogen peroxide gels in percentages of 6 to 15%. And we'll talk about what the chemical equivalents are of carbamide to hydrogen peroxide. They're using soft polyvinyl trays. There's significant evidence of clinical success and safety. In fact, most of the research on these whitening products was done in the late 1990s, early 2000s. You'll see very few studies and very few articles on these products because they're quite a bit of evidence saying they work successfully. We don't have to repeat that research data. Using vital bleaching with trays gives us decreased chair time. Remember, chair time is an expense to the dental office, and the adverse reactions are very minimal. So how does bleaching work? Well, let's say we take a 10 to 15% carbamide peroxide and we put it in a tray, and the tray is put in the patient's mouth. Over the first 30 to 40 minutes, the carbamide peroxide starts to break down into its active ingredients, hydrogen peroxide. It also breaks down into urea, which is why it's a carbamide product. The hydrogen peroxide is our active ingredient because when the hydrogen peroxide breaks down, it breaks down into oxygen ion and water. The urea breaks down into ammonia and carbon dioxide. And really, it's the hydrogen peroxide that's the active ingredient that's giving us the tooth whitening. It's breaking up the stain. It's very similar to breaking up the stain when we're bleaching clothing, bleaching anything. So how does bleaching work? Well, the oxygen ion penetrates the enamel in the dentin when it's in close contact with the tooth. That's why the white strips need to be in contact with the enamel surface. The oxygen ion attaches to the double bond of the stain. It breaks down that double bond, allowing the stain to be broken up and removed from the tooth. This oxygen ion and what it's doing is similar to the same type of bleaching that you see with any type of bleaching procedure. And the effectiveness of bleaching is based upon the number of oxygen ions. The higher concentrations work more effectively, more efficiently. They work faster. And the duration of exposure. If you put a bleaching product in the mouth for only 30 seconds, it's not going to be as effective as if it's in the mouth for 30 minutes. So it's a balance between the number of oxygen ions, the concentration of the bleach, and the duration of the exposure. Let's take a look at the differences between carbamide peroxide and hydrogen peroxide. First of all, the equivalent 3% hydrogen peroxide is approximately equivalent to 10% carbamide peroxide. So typically you're going to see for uh, at-home use lower concentrations of hydrogen peroxide when compared to carbamide peroxide, but they'll have equivalent success. A term that's frequently used is the term bleaching potential. Bleaching potential refers to the differences between carbamide peroxide and hydrogen peroxide. The difference between I can wear a tray for 1 to 2 hours or overnight versus I can wear a tray for 30 minutes. And in fact, different companies will label products based upon their usage. Night White, which is a bleaching product from Discus Dental, comes in concentrations of 10%, 16%, 22% carbamide peroxide with a desensitizing agent, amorphous calcium phosphate ACP. And it's referred to as night white, meaning it extended wear. Day white is not an extended wear product, and you can see it has higher concentrations, lower concentrations of 7.5% and 9.5% of hydrogen peroxide, once again with a desensitizing addition of ACP, amorphous calcium phosphate. So let's take a look at the bleaching potential overnight of a carbamide peroxide. Remember, I said that carbamide peroxide is for extended wear. And when we talk about this concept of bleaching potential, it means that the bleaching agent is releasing free oxygen radicals overnight. And this research demonstrates it. So if we put a tray in the mouth that has carbamide peroxide and we then measure in 15 seconds the amount of bleaching agent of oxygen radicals that are available, you can see that from 15 seconds, we're at the 87% range. It drops down at 1 hour to 69%, at 4 hours to around 35%, at 10 hours, 10%. But we still have active bleaching ingredient, free oxygen radicals available for whitening teeth. And so carbamide peroxide is for extended wear of trays during the day or when sleeping at night. We compare the peroxide release of hydrogen peroxide compared to carbamide peroxide. Now, I just told you carbamide peroxide is for extended wear. It has a higher bleaching potential. Hydrogen peroxide somewhat differently. In fact, hydrogen peroxide releases 50 to 100% of its peroxide, the oxygen radicals, in 30 minutes or less, with a rapid decline, this yellow graph on the lower left. The carbamide peroxide releases 50% in 2 hours, then a slow decline due to the fact that carbamide peroxide has a carbapole in its chemical formulation in the gel formulation. And the tooth can only change color at a certain rate. You can't expect tooth stain to be broken up in 15-20 seconds. It takes that half an hour. Half an hour either with carbamide peroxide, half an hour with hydrogen peroxide. And so hydrogen peroxide is what's in the white strips. Whether it be professionally dispensed or over the counter, it means that a person would put a white strip in the mouth for 30 minutes, the time it takes to commute, or perhaps drive carpool, take it out of the mouth and throw it away, and then twice a day, so when you pick up carpool or pick up or drive home, you can put strips in again, so that over a 2-week period of time, you have whitening occurring over the 30 minutes twice a day versus wearing a tray overnight with carbamide peroxide or wearing a tray for 1 to 2 hours. If you're using a hydrogen peroxide product in a tray, you're looking at its effectiveness really is over 30 minutes to an hour. Now, one of the most commonly reported adverse reactions when whitening teeth with peroxide products is tooth sensitivity. In some cases, the sensitivity is so severe that patients will stop wearing the mouth guard, stop wearing the tray. In fact, different studies report anywhere between 6 and 50% of the patients having bleaching report sensitivity. In some patients, they're able to overcome that sensitivity and wait. It usually occurs within the first 1 to 4 days, and it then decreases over time. The higher the concentration, the greater the likelihood of the patient having sensitivity. So we see tooth sensitivity with bleaching, and a number of studies have reported it. In Van Hayward's study in 2003, where he looked at and did an overview of all the bleaching studies, they reported rates as high as 55 to 75% of the patients who had sensitivity when undergoing vital bleaching. Typically, this was tray bleaching. They found that the tooth sensitivity is transient, meaning that when I remove the tray, the sensitivity goes away. They made recommendations to minimize tooth sensitivity to include the clinician can recommend the patient decrease the time the tray is worn during the first week to no more than an hour a day for carbamide peroxide products, or for higher concentration hydrogen peroxides as little as 15 minutes a day. And then after a week, increase that time, bleaching between 2 and 3 weeks. Other things that can be done to minimize tooth sensitivity is to use a desensitizing toothpaste and a bleaching mouthguard. Any toothpaste that's a sensitivity toothpaste with a 5% potassium nitrate, placing it in the tray for 1 week before starting bleaching. Leave that toothpaste in the tray for about an hour, and then rinsing it out. After the first week, then use the toothpaste in the tray for about an hour before you start using mouthguard bleaching materials. And these have been effective strategies for patients to tolerate the sensitivity and to overcome the sensitivity. Also, some of the companies are adding amorphous calcium phosphate to their bleaching agents, and you'll also see bleaching agents that have fluoride added to them and potassium nitrate. And the studies show that these do decrease sensitivity, the potential for sensitivity. And there are a number of different products, as I mentioned earlier, that have amorphous calcium phosphate added to them, from Discus Dental. Ultradent adds fluoride and potassium nitrate to their products. And so we know that the addition of amorphous calcium phosphate and or fluoride and potassium nitrate decrease sensitivity. And once again, the studies are demonstrating that we see effectiveness with these products. What are the most commonly reported adverse reactions by patients? Well, sensitivity is definitely the highest. It's followed by gingival irritation, and depending upon the study, 5 to 30% of the patients report irritation, and that generally is because the tray has been fabricated on an inaccurate cast, or the tray hasn't been trimmed properly. Some patients report a throat irritation, and we find that for those patients, they're overusing the bleaching gel and swallowing it. Some patients have difficulty adjusting to the mouth guard. Remember, it's going to be in the mouth and it will interfere with occlusion. Patients report with the strips that there is difficulty applying the strips. The maxillary strips are much easier to apply than the mandibular strips. Patients report tongue irritation, less than 1%, but there are some, and once again, the tongue irritation can relate to the tray not being trimmed and smoothed properly, or an overuse of the bleaching gel. One of the things that we always concern ourselves with is, are the products we're using intraorally placing the patient any risk to pathology? In the case of peroxide products, there are studies that have been done looking at the mutagenicity and the carcinogenicity of peroxide products. And so when we review a comprehensive review of the evidence, looking at research and available literature, and we look at the use of peroxide-based tooth whitening products, that peroxide-based tooth whitening products do not appear to pose an increased risk of oral cancer in the general population. This includes patients at a higher risk, those that are alcohol abusers and heavy smokers. So we're using these bleaching products, we're usually using them effectively, and it really comes down to patient selection for bleaching. Whose teeth shall I bleach? What's your evaluation of the discoloration? And how do you predict prognosis of bleaching? So you need to start with a diagnosis. Uh, why does the patient have tooth discoloration? And is the discoloration treatable using whitening products, peroxide bleaching products? So let's take a look. Uh, Patients who have mild tetracycline staining, that's antibiotic staining, patients with mild fluorosis, and we'll look at fluorosis later in this presentation, teeth that are non-vital, teeth that are non-vital due to trauma to the teeth, either due to after endodontic treatment or non-vital teeth that have endodontic staining. Aging discoloration, as we get older, the enamel gets thinner and the dentin shines through, or as we get older, more stain builds up on the teeth. Patients with oral habits that cause staining, such as food staining and smoking staining, beverages, red wine, cola beverages can all cause staining of the teeth, and that occurring with these acidic beverages or etching the enamel surface, the discolorations embedding itself in these etched enamel surfaces, and when the teeth remineralize due to the saliva, these stains are trapped. And for those patients, bleaching is an option. And these are typically the much milder situation that we can use bleaching, whether it's non-vital bleaching, whether it's bleaching using in-office bleaching, or whether it's bleaching using over-the-counter products or professional bleaching with tray bleaching. Now, there are certain oral conditions, white hypoplastic spots, deep white spots, severe fluorosis causing discoloration, that the appropriate treatment is a restorative intervention with composite or porcelain veneers, where bleaching is not going to be effective. And so we need to give the patient correct guidance as to what the correct treatment option is for an aesthetic change. When teeth have very severe discoloration, severe tetracycline staining, very dark staining of the teeth, or endodontic staining that's extremely dark. In those patients, placing veneers, porcelain veneers, or crowns is the appropriate aesthetic treatment. And when you go through treatment planning and you start to see patients, you'll see how the age and whether or not the patient has tried different bleaching techniques in the past to help give them guidance as to what the appropriate treatment would be to get the aesthetic result they desire. So let's go through the clinical protocol, the techniques for mouthguard bleaching. And when we say mouthguard bleaching, we're talking about a thin polyvinyl flexible tray that's made to fit over the teeth. And we'll look at how to fabricate these bleaching trays. First, you need to document the shade. You'll use a shade guide. You may use an intraoral camera. You'll compare the teeth, both maxillary and mandibular arch, and you'll make a notation. What color discoloration do the teeth have to start with? The photograph can be very helpful in looking at that, using a shade guide and documenting the shade so that if there are any clinical changes during the procedure, you can note them and the patient can see visually that there is a change. Some products actually provide the patient with a cardboard pre-printed shade guide so they can evaluate their own progress. We're going to make an impression, pour a cast, make sure the cast is accurate. We're going to remove all defects on the cast and we're going to trim that cast for fabricating the tray. We're going to fabricate the mouthguard. Some manufacturer products recommend spacer, and we'll see an example in the videotape of putting a spacer on, and we'll look at what the research says about using a spacer, basically a reservoir, in the tray. Do you need to scallop the tray? Basically, scalloping refers to that we trim the tray with a scissor to follow the free margin of the gingiva. With 10% carbamide peroxides and 5% hydrogen peroxides, there's no need to scallop a tray. But when you start to go to higher concentrations, scalloping makes good sense to not irritate the interproximal papilla. In fact, in most dental practices today, the use of higher concentrations is what's being used because the initial bleaching occurs faster, even though over the course of the 2 to 3 weeks it does stabilize, and whether you're using a 10% carbamide peroxide, a 5 or 6% hydrogen peroxide, that over time the color stabilizes. But patients want the higher concentration. At the school, we use a 10% carbamide peroxide to minimize the postoperative bleaching sensitivity. You make the tray, or in your dental practice, an assistant would make the tray, and you'll try the mouth guard in the mouth. You don't want to mail it to the patient and just tell them to use it. You want to make sure that it's fitting well and that the patient can actually follow the instructions for using the bleaching gel and the mouth guard. So you're going to give the patient instructions. In fact, in my practice, what I typically do is I give the patient the tray. I watch them place the bleach in the tray so I can guide them how much they should place in. I have them place the tray in the mouth and have them wear it home or to where they're going, and then they can take it out of the mouth and rinse it off in the bathroom, and they've had the experience of using the bleaching mouth guard. You'll give them the bleaching agent, you'll give them instructions, and you'll send them on their way. Your first post-op check will be the first 2 weeks. Typically, my patients are bleaching over 4 to 6 weeks to get the optimum bleaching potential of the products that we're using. Let's take a look at trimming the cast and having an accurate impression. And this video can be watched separately and apart from this lecture. You need to make accurate impressions. Don't use duplicated casts. Make an accurate impression. You're going to trim away the land area on the buccal vestibule, and you're going to trim away the lingual surface. We're going to take it to a model trimmer, make sure it's an accurate cast, and you can see that the tongue space has been removed. On a maxillary arch, we'll be removing the palate. We're trimming the cast so that there's no land area, so that when we suction down the bleaching tray material, that bleaching tray material will adapt well to the teeth and to the soft tissue. On the maxillary cast, once again, we're trimming it, and you'll notice that the land area on the facial is being removed. Also notice the palate's also being removed. We're going to make the bleaching tray to a horseshoe shape. I'm here trimming away the buccal so that it will suction down. And this is critical to get a well-adapted bleaching tray. You don't want to cut any corners. You can see in a matter of 10-15 seconds I've trimmed that tray. I've trimmed the cast so there's no vestibule area, no lingual. And here we're looking at a maxillary cast ready to have the tray fabricated. For the clinical protocol for the Ultradent product that we're using, the opalescence, we can fabricate the mouth guard with a spacer. The spacer is applied, and then the mouth guard is suctioned down, and then we're trimming it to scallop it. And you'll notice that that when you're scalloping it, it creates a reservoir. We know sensitivity can occur when bleaching. For sensitivity, we can use a desensitizing toothpaste in a bleaching tray for an hour a day for 1 week and then bleach the teeth. Let's take a look at making the tray. And this video, once again, can be watched separately. And this is a commercial video called that. I'm sorry, there was a problem with that video. We'll have you watch that video separately. So here we've taken the cast and we've trimmed it down into a horseshoe shape. This is a maxillary cast. We've suctioned down the bleaching tray material, and we're now scalloping with a scissor the tray. What I want you to note is that there's a slight amount of tray material beyond the where the spacer was applied. If you were to trim all the way to the spacer, the bleaching will still work. It's not recommended. Do you need a spacer? Do you need reservoirs? Well, the research says that we don't need any reservoirs. We don't see any differences in the whitening. We don't see any difference in the gingival sensitivity. But depending upon what practice you work in, there may be a practice where they want to use reservoirs, use the spacer. You don't want to get into an argument. Whoever you're working for, whatever technique they're using successfully, that's the technique you can follow with. So let's take a look at some case reports. Here we're looking at a patient who's bleaching their teeth that are yellow due to food and beverage, smoking, staining, perhaps some mild fluorosis. Using bleaching trays for 2 weeks, they were able to whiten the maxillary arch. Now they're ready to start the mandibular arch. And you can see that the patient has as a reference that the upper teeth are whitening because the lower teeth were not whitened. Typically, I'll have the patient wear a tray for 2 weeks in the maxillary arch. Then I'll give them the tray for the mandibular arch. The enamel's thinner on the mandible, and that'll bleach faster. Also, when they're bleaching and they're wearing both trays, maxillary and mandibular, they don't think it's working because they can't see a difference. Wearing a maxillary tray first, they can see the difference between the upper and the lower arches. Or for this patient who was unhappy with the color of their teeth, once again wearing the tray for 4 weeks, they were able to whiten the maxillary arch when compared to the mandibular arch. And patients are happy with tooth whitening. It's a very non-invasive technique that provides patients with an aesthetically pleasing result. Now, I mentioned tetracycline staining. Tetracycline staining is antibiotic staining. The antibiotic tetracycline gets incorporated into the dentin of the teeth. It's a dentin stain, and actually also into the bones. And this antibiotic staining, that when exposed to ultraviolet light, and that's the ultraviolet of sunlight, of natural lighting, over time causes the dentin to discolor. That dentin shines through and discolors the enamel. The enamel's fine, it's the dentin that's discolored. In fact, where the enamel's thinnest, at the cervical third, is typically a darkened area. More prevalent with baby boomers than with your generation. And you will see less and less of tetracycline staining today. In fact, in order to whiten with bleaching trays, you'd have to wear the trays every night for 6 months. And even when doing that, and here for the maxillary arch, this is a case by Dr. Van Hayward, Medical College of Georgia, where the enamel's the thinnest, the dentin discoloration is shining through. For many of my patients, they'd rather choose a restorative option, typically porcelain veneers. Now, there are other discolorations that can be treated with bleaching, but typically we use a combined technique of what's called microabrasion or macroabrasion and bleaching. First of all, we're looking at a discoloration called dental fluorosis. You may have heard of that. Dental fluorosis is a hypomineralization of the enamel that results from excessive ingestion of fluoride during tooth development. This is a patient with a moderate case of fluorosis. You'll hear the term mottled enamel. Mottled enamel refers to fluorosis. The index for fluorosis staining, if we were to gauge it, is the Dean's fluorosis index. And you can see that the scoring goes from normal to questionable, meaning that the enamel may or may not have fluorosis, or it may be extremely mild. We have very mild fluorosis, mild, moderate, and severe. And this is from Dr. Dean, who created this index back in 1942. If we were to look at the statistical evidence from the Centers for Disease Control, CDC data, in terms of individuals having fluorosis, generally looking at children and adolescents, uh, you can see that in the age group of 12 to 15, uh, about 51% have no fluorosis at all, 12% some questionable fluorosis, it may or may not be, and very mild, 25% have very mild fluorosis. In fact, the numbers run parallel for young adolescents and older adolescents. And you can see that when we get into the 20 to 39 year range, that fluorosis is less of a problem for that age range. And this is looking at data from 1999 to 2004. But fluorosis is an aesthetic problem. It's not a pathologic condition. It's a visual condition of teeth that occurs because of ingestion of too much fluoride. Or fluoride may be incorporated into the natural water supply. And so, based upon scientific assessments that the EPA and health groups have taken the goal to reduce fluoride in the water supply. The optimum fluoride was changed to 0.7 milligrams per liter. And so the goal of fluoride supplements is to provide an optimal amount of fluoride to reduce the risk of dental caries. And this reduction is based upon recent recommendations to move fluoride from, in some cases, 2.2 milligrams per liter down to 0.7. The reason for doing that is the aesthetic concerns that people have because we were seeing an increase in fluorosis. This article by myself and Dr. Griffin and Dr. Maggio is part of your readings that goes through and gives you an update and an overview of fluorosis. And you can see the 3 clinical cases on the cover sheet of this article. An example of a mild fluorosis discoloration, the top image, a moderate fluorosis, the middle image, and a severe fluorosis patient in this lower image. And you can see the moderate and severe can be aesthetically disfiguring. So how do we treat fluorosis staining? How do we treat it with minimal invasive techniques, conservative techniques? Well, for mild and moderate fluorosis, we have evidence that we can use a macro-microabrasion technique combined with the use of bleaching agents. Here we're looking at a mild fluorosis patient, and this case is in one of your readings to review exactly why the fluorosis occurred. The clinical treatment technique we'll be using will be called microabrasion. Microabrasion refers to the use of hydrochloric acid in an abrasive paste, which etches and physically abrades the etched enamel, removing a superficial layer of the enamel, typically 2 to 3/10 of a millimeter of the enamel. Macroabrasion refers to the use of a fine abrasive diamond similar to the one you use for finishing composite, typically a 50 to 75 micron grit diamond, using it in a high-speed handpiece with lots of water spray, and you can get a more rapid removal of the discolored enamel. And we're usually using it when there's deeper superficial enamel staining and discoloration. There will be circumstances where both microabrasion using the abrasive paste or using a macroabrasion technique with a fine composite finishing diamond may not be sufficient to meet the patient's aesthetic needs. In those cases, the use of veneering techniques, porcelain veneers, or crowns may be necessary. Let's talk about treatment planning, macro and microabrasion. Well, first of all, it's for superficial enamel staining and discoloration. The staining and discoloration are typically that mottled enamel discoloration due to mild to moderate fluorosis, mottled referring to brown specks and brown and white specks on the enamel surface. It also can refer to superficial enamel discoloration caused by enamel demineralization, remineralization, uh, and we might see that around a patient who's had orthodontic treatment who was not effective at removing the biofilm, the plaque, and the teeth demineralized and remineralized, and you'll see discoloration, white or brownish staining. Uh, when you see deeper enamel discoloration where it's not superficial, that it's best treated with a restorative material intervention, composite veneering, porcelain veneering, or crowns. So let's take a look. For this patient, we're going to do a combined macroabrasion, microabrasion technique for this mild fluorosis staining. A dental dam is placed. We are going to use a hydrochloric acid gel, and here we're using a fine diamond on a high-speed handpiece, and we're abrading away the superficial layer of enamel with a significant amount of water spray to depths of about 2 to 3/10 of a millimeter. Uh, uh, we can then apply or use a microabrasion gel. So both techniques work effectively. In this case, we're using the product Opal Luster from Ultradent. It's a violet-containing material. It has a carborundum abrasive particle in it. It's about approximately a 12% hydrochloric acid. Hydrochloric acid can cause gingival burning, and hence the use of a dental dam in place. Okay, so here we're looking at the left side has been macroabraded with a fine diamond, and you can see the difference in the color of the surface of the enamel compared to the side not treated on the right. You can see that some of the modeling has changed its superficial enamel staining. We then finish this case off on both sides with the fine diamond, followed by the use of the Opal Luster. And this is not a prophy cup, but rather a cup that comes with the Opal Luster. It has a brush inside, and we're running the handpiece on the number 1 setting of your slow speed. The number 1 setting, you're running it at 1,000 RPMs. You don't want to run it any faster because this gel is going to splatter, and we don't want to do that. It means that you need to wear eye protection, your assistant needs to wear eye protection, the patient absolutely needs eye protection. Okay. After the use of the diamond, and then one time with the Opal Luster, you can see we have some change in the coloration of the enamel. You'll also notice the enamel is no longer shiny because we've acid treated it. Here it's after 3 times with macroabrasion first, finished with microabrasion. And you can see that here we're looking at around the gingival some of the abrasive grit that when we rinsed it off, it was still remaining on the enamel surface. We then will remineralize the acid-treated enamel with fluoride or an amorphous calcium phosphate. Before we do that, we go in with an enhanced polishing cup, and we polish the etched enamel back to a smooth surface. We can then apply topical fluoride to these teeth to remineralize them. Remember, they've been acid attacked with a high concentration hydrochloric acid. So this is after remineralization of the acid-treated enamel with fluoride, and we also use an amorphous calcium phosphate paste, and after polishing with our enhanced polishing cup. So our pre-operative view of mild fluorosis, and postoperatively after one treatment. And you can see the change in the mottled enamel appearance to a more aesthetic appearance that's more pleasing to the patient. Patients still want to know, can I make these teeth whiter? And so we fabricated a bleaching tray and gave the patient a 15% carbamide peroxide. So we're going to give the patient a bleaching tray and do 3 weeks of at-home bleaching. So after we finish the macro and microabrasion to treat the fluorosis, and then 3 weeks of bleaching, the patient was now satisfied with the result and the tooth whitening of what we did. Here we're looking at the bleaching 2 years post-op and the fact that there is stability to the bleaching. Let's take a look at some other cases. For this patient, the patient had orthodontic treatment, and in some cases, when patients finish the orthodontic treatment and they want to do whitening, there may be residual resin, as you can see here, on these teeth. The patient wore the bleaching mouthguard for 2 weeks, and they reported the fact that they had these yellow bullseyes on the teeth. What was going on? We realized that this was residual resin left after the brackets were debonded. We removed the resin using an enhanced polishing disc from the enamel surfaces. We went from canine to canine. We then had the patient use the bleaching gel again for another 2 weeks, and after 2 weeks of bleaching, they were able to even out the color and get the whitening effect that they wanted. In cases where the patients have retainers that are vacuum on, those retainers can be used as bleaching trays for the patient. Can teenagers bleach their teeth? Well, studies have been done to show that teenagers can bleach their teeth and that it's safe to bleach their teeth. Here we're looking at a teenager who's going to do tray bleaching after the orthodontic treatment has been completed. They then do tray bleaching. Here it's 10% carbamide peroxide in the maxillary arch. For this teenager, if restorations are planned, bonding restorations for the peg-shaped and undersized lateral incisors, it would be recommended that they bleach first and then you choose your composite or ceramic shade after the bleaching. You've just been watching an update on vital bleaching, the background chemistry, and at-home whitening.